Welcome back to the last part of this winter edition liver seminars. It's a true pleasure for me to introduce our next speaker, Dr. Ripoll. Dr. Ripoll is a renowned expert in the field of portal hypertension and the complication of chronic liver disease. She is professor of medicine and hepatologist at the University Hospital of Jena in Germany and serves as vice secretary of the executive committee of the Isel-Baveno Cooperation Group. Dr. Ripoll earned her medical degree from the University of Alicante in Spain. Then she traveled to Madrid, where she completed her gastroenterology residency in this center, and her PhD studies in Universidad Complutense, also in Madrid. Afterwards, she continued her training in portal hypertension and relational research at the Yale University with Dr. Grossman and Dr. Garcia-Sau. And in 2012, she moved to Germany, where she has continued working as clinical hepatologist, leading at the same time several national research projects. She has also held key roles, such as the Portal Hypertension Special Interest Group of the American Association for the Study of the Liver. Dr. Ripoll's research has mainly focused as a patient-oriented research in the field of the complications of cirrhosis. She has authored over 100 papers, chapters, reviews, and more recently several society guidelines and position papers. Today, Dr. Ripoll will share her insights on the natural history of cirrhosis and pathophysiological mechanisms, a topic of great relevance to all of us. So, without further delay, join me in giving a warm welcome to Cristina. Thank you, Cristina.
Thank you very much, Luis. For me, I would like to first of all thank the organizers, Jordi, and all of the other organizers, Javier, who's not here anymore, unfortunately, for this possibility to come here to Madrid. I trained here in this hospital. It is for me a great, true honor to be here and to be able to give this talk today. And I will be talking about the natural history of cirrhosis and the pathophysiological mechanisms in cirrhosis. So here's an outline of my talk. And first of all, I want to talk about the natural history. So when we have chronic liver disease, and this is an inflammation in the liver that happens over years, decades, this can eventually come to a compensated cirrhosis. Compensated cirrhosis is a stage of the disease in patients who do not have, obviously, and have not had previous decompensation. These patients it's interesting to know this from the patients because a patient who is compensated has a very good survival in the long run. So a true compensated patient, a patient who has never had any problems, has a median survival well above 10 years, as long as he maintains compensated. Then some patients, not all patients, but some patients will develop their first decompensation, which has been defined as the development of ascites, variceal bleeding, and hepatic encephalopathy. So the development of the first decompensation in the natural history of the disease, this has a big impact in survival, and the most frequent first decompensation is ascites. And for those of you who are not clinicians, we can see here how this looks. Here we see pictures of gastrointestinal endoscopy. This is the esophagus. You can see here the varices, and a varus which just doesn't bleed has no relevance in the sense that it's not clinical decompensation. But here we can see what it looks like when it's bleeding. Here we have the typical picture of a patient with ascites, and here was a physical examination of flapping, which is asterixis, which is a sign, or which can be a sign or can be seen in hepatic encephalopathy. If the patient continues to evolve towards death, this patient will develop further decompensation, and this was defined in the past Baveno Consensus Conference as the development of a second event. So this is the most common patient we have first comes with ascites, and then this patient eventually has variceal bleeding or a hepatic encephalopathy. Or the patient has an infection and comes with a jaundice, for example. Another possibility for further decompensation is the patient who has a variceal bleed and comes again with a second variceal bleeding, a recurrent event. And then in the ascites, because ascites is a big family of complications. So we have first ascites, and inside of the ascites family, we have, for example, the topic that Salvatore spoke about before. We have refractory ascites, SBP, and so on. For the presence, obviously, this sounds a bit simple, but it's important to say patients who have developed further decompensation, obviously, have a high incidence of a high 5-year incidence of death. Around 55% of patients will be dying after 5 years. And here we can see in this study recently published from Gennaro D'Amico y Lupe, also with data from Halle, they saw that these are the states of the patients within 5 years. So here we see the patients alive with first decompensation, alive with further decompensation, those who were transplanted, which is obviously a minority of patients, and then we have the death after first, or the most common death after further decompensation. So this is the natural history that we consider in especially in the Baveno context. But there are overlapping concepts, and for people who are not into this natural history or natural course of the disease, this can be very confusing. There have been other concepts that are also used in the literature of natural history of cirrhosis, and this is the concept of acute decompensation. Acute decompensation was defined for the canonic study. This was a criteria for entering the study, which further on went to define the acute on chronic liver failure, which is a very relevant event in the course of cirrhosis. And as contraposition to acute decompensation, you have the non-acute decompensation, because obviously the acute decompensation are those patients who are hospitalized with ascites, hepatic encephalopathy, a gastrointestinal bleed, jaundice, or infections. And the non-acute patients are those patients who are decompensated but at home, that are not requiring hospitalization. And there's an important difference in this view compared to the other view that I have just previously exposed that I would like to underline. This definition is a snapshot. It's a moment. The patient is in the hospital. We do not look at the past. It doesn't make a difference, or the patient with acute decompensation, we don't look at if there was previously compensated, whether it was first decompensated, where this patient is in the natural history. This is a moment, a patient with acute decompensation, whereas the other one looks with time at the course of the disease. And patients who have acute decompensation has been further divided, and this leads to further confusion, but it's very interesting that different trajectories of the disease have been described, and this is the presence of so these are patients with acute decompensation, who can then have stable decompensated cirrhosis. This concept is defined as the patient who is after 90 days at home. That's it. And then patients who are unstable decompensated cirrhosis, who are hospitalized after 90 days, and the pre-ACLF patients, which are the ones who go on to develop ACLF within 90 days. So this is just to clarify these different concepts, which may be leading to confusion when we talk about decompensation. Then you have acute decompensation, and so on and so forth. So as I showed you, so this is the course of the disease from chronic liver disease to death or liver transplant. What I did not say before, but it's very important, is that along the course of the disease from compensated cirrhosis to death and liver transplant, you can also have hepatocellular carcinoma. Not all patients with cirrhosis develop hepatocellular carcinoma. Hepatocellular carcinoma is not the worst thing that can happen for a cirrhotic patient. You can have other things that are also pretty bad, actually. And patients can have and this is my own opinion, superimposed liver injury, which in its worst form, for me, and the way I see it, is acute on chronic liver failure. Acute on chronic liver failure, and this is not my opinion, is a clearly defined entity where there's organ failure, and these patients have a very high risk of death within 3 months. In the past Baveno Consensus Conference, and this is very interesting for me because when I was in medical school, I was told that cirrhosis is irreversible. And this one, you have a cirrhosis, and this is a horrible thing, and you cannot get out of this. But in the recent years, we are identifying patients who go actually the other way. No, so they go from further decompensation, first decompensation, back to a sort of compensated stage. And this event was defined, and this is an arbitrary definition, which we can discuss as long as you want afterwards, is called recompensation. So for recompensation, the essential thing, and I think this is very important because you also see in the literature or discussion in courses and in congresses, we talk about recompensation, which is perhaps just that the patient's on diuretic and it's okay. For recompensation, the essential thing is the control of or suppression or cure of the etiology of the cirrhosis. This is for me the essential thing that you achieve. Because you remove the cause of the liver disease, you do not have further inflammation in the liver, and you have this ascites. You saw previously the pictures. The ascites resolves, but it's not resolved that he's on diuretics and it's minimal ascites. No, it is that in the outpatient clinic, you can take this patient off the drugs. And obviously, as people who treat patients, a patient who takes a lot of pills is very, very sick, especially in the patient's mind. More pills, more sick. When you take him off pills, this is a very rewarding event for the patients. They see that they're doing better, especially those who stop drinking is very motivating. So that you can see you can take them off the diuretics, you can take them off the lactulose that you have them on to prevent further encephalopathies, and these events remain absent in the next year. So this is the definition of recompensation. And you have to see also a stable improvement in liver function tests, albumin, INR, and bilirubin. And this has to go from a conceptual point of view, should go along with a regression of fibrosis. This is the definition of recompensation that was proposed in the past Baveno. There are challenges to this definition. In my opinion, one of the biggest challenges is because, we're not just hepatologists who live in our little bubble, but we work with other specialists, and recompensation in other fields is just the reversal of an acute decompensation. And for example, I'm thinking of heart failure, where you have an acute heart failure and you recompensate the patient and he goes home. So I think that this is one of the challenges. There are also other challenges. And we can also discuss whether 12 months is necessary, and other further points that are in discussion. It's a very hot topic, actually, in the present history. The first studies that were published regarding recompensation, or the best population group to evaluate recompensation, is the patients with viral hepatitis B mainly. Because in this study, which is from the Chinese group, they had 283 decompensated patients with hepatitis B who were started on effective antivirals. And we can see after 48 weeks and 120 weeks, the child Pew score of all patients, and here of the subgroup, and this was 171 patients who had resolution of their decompensation from the 283, and we can see the child Pew score, or the child Pew grade, from these patients. However, we should not confuse. Child Pew A is not recompensation. You can have ascites and be child Pew A with 6 points. To go into the pathophysiological mechanisms in cirrhosis, Salvatore explained very beautifully about these mechanisms. I will have a little bit of overlap, but I think that's totally okay. In the development of the disease, you have, on one hand, portal hypertension, you have liver insufficiency, and Salvatore talked quite a bit, much more than what I will do, about systemic inflammation. So first, let me go through I will go very, very superficially and not in depth into these mechanisms. But first of all, a portal hypertension. So in portal hypertension, you have an increase in intrahepatic resistance. This is mainly due to architectural distortion, but there is a component that is due to vascular tone, and therefore this can change with vasoconstrictors, obviously. This leads to portal hypertension, which leads to splanchnic vasodilation. This was also explained by Salvatore, which leads to a decrease in systemic vascular resistance, activation of vasocompensatory, vasoactive mechanisms which increase cardiac output, lead to sodium retention in the kidney and water, which leads to ascites, and leads to also to an increase in portal venous flow, which perpetuates the portal hypertension. And obviously, because of portal hypertension, you develop collaterals. These are the varices, which variceal bleed is a consequence also of portal hypertension. Would be how portal hypertension sees systemic inflammation is in cirrhosis, as Salvatore explained. This has been seen, it was also previously known that you had cytokines and endotoxin, but the relevance of systemic inflammation has been identified since the proposal of the systemic inflammation hypothesis in 2015. And in this case, you have the pathogen-associated molecular patterns, you have the damage-associated molecular patterns, which is sterile, and you have obviously cirrhosis-associated immune dysfunction. And this systemic inflammation interacts with these portal hypertension because, as I previously said, you have cirrhosis, you have portal hypertension. This leads to systemic arteriosis, the splanchnic arterial vasodilation. But because of the portal hypertension, you also have bacterial translocation with the PAMPs. And because of the inflammation in the liver, you have tissue damage with the DAMPs. And this leads to an innate immune activation, pro-inflammatory cytokines, reactive oxygen nitrogen species, and this in itself worsens this splanchnic arterial vasodilation and leads to microvascular dysfunction through different mechanisms, and these eventually can lead to end organ dysfunction. Liver insufficiency, in my opinion, liver insufficiency is the pathophysiological mechanism of cirrhosis that we have not paid enough attention to. We know that we have, in cirrhosis, you have a hepatocyte dysfunction, and you also have parenchymal extinction. So very advanced cirrhosis has very small livers. So it's obviously you have less mass of cells doing whatever they do. And I think this is not very well studied, and I think that this would be interesting to further go into to gain more knowledge and to be able to understand better everything that's going. I will further discuss the interaction, and this is what I find incredibly interesting, the interaction between these pathophysiological mechanisms, first in compensated cirrhosis, then in decompensated cirrhosis, and then I will talk about the effect of treatments aimed on these pathophysiological mechanisms. So compensated cirrhosis, for those of you who are not so used to these terms, compensated cirrhosis, again, is a patient who does not have and has never had any of these clinical events of decompensation. And we know that along the natural history of compensated cirrhosis, we have a progressive increase in portal pressure. Portal pressure is estimated with this HVPG, which is hepatic venous pressure gradient. And there is a cutoff of hepatic venous pressure gradient, which is called clinically significant portal hypertension, which is a hepatic venous pressure gradient above 10. So obviously, if these are patients without clinically significant portal hypertension, which by definition have a lower HVPG. We have patients without varices, compensated but without varices, who have clinically significant portal hypertension. And then we have patients who have varices and obviously clinically significant portal hypertension. And you see here that the HVPG increases progressively. The presence of clinically significant portal hypertension, this HVPG above 10 in patients who have compensated cirrhosis, identifies the risk group with high risk of first decompensation. So this transition to first decompensation is the transition from a good prognosis situation to a marked worsening in prognosis. So this is very important to identify this risk group. This was seen years ago, but this study here was done where we can see here the incidence of first decompensation in patients with clinically significant portal hypertension. This study was done in a population of mainly hepatitis C patients. And this has been recently reevaluated in MASL-D. And in MASL-D, of course, in MASL-D, there's sort of a pre-sinusoidal component, so you can have decompensation with lower levels of HVPG, but again, HVPG above 10 marks the risk group of development of first decompensation. And if you look at the independent predictors in multivariate analysis in these studies, the independent predictors of first decompensation in this study was HVPG, MELD, and albumin, and in this study it was exclusively HVPG. And we can see that the two studies, which are done in different countries of the world with different study populations with different times, have very similar magnitude of the effect, so that each 1 millimeter of mercury increase in HVPG increased the risk of decompensation 11-12%, which I find is pretty cool because it's maintained robust over the years. What about the inflammation in the compensated patients? So, you know, in this study from Thomas Reiberger from Vienna, he evaluated systemic inflammation by means of what you can measure easily in blood, which is reactive C-reactive protein and interleukin 6, and he again evaluated the study populations with all compensated cirrhosis, without clinically significant portal hypertension, without varices, and finally the clinically significant portal hypertension with varices. And we can see here that we do not have a clear trend, although some patients seem to have a certain degree of inflammation. We have seen this is a smaller group of patients from Halle and also from Hamburg, where we evaluated the presence of NOD2 risk variants. With NOD2 risk variants, as you know, are associated to an increase in intestinal permeability. And we saw in these compensated patients with NOD2 risk variants that although in the whole group, and these were 360 compensated patients, the presence of NOD2 risk variant had no influence on the development of first decompensation. In the subgroup of patients with varices, this presence of this seemed to have an effect on the incidence of first decompensation. And we know that some patients have increased systemic inflammation, which can then lead to liver-related events. And this is a study from the group of Jonel now in Münster. And in this study, he evaluated serum interleukin-1 alpha as a marker of hepatic inflammasomes, and he evaluated compensated and recompensated patients. As you can see here, the compensated, here the recompensated patients. But I want to focus on this part of the graph. And here, what they saw is that patients who had compensated cirrhosis and who had undetectable interleukin-1 alpha and a low CLIF AD score, which is a score that is to evaluate the prognosis of patients with acute decompensation. These patients had a lower likelihood of developing fatal acute on chronic liver failure and follow-up compared to patients who had a detectable interleukin-1 alpha and a higher CLIF AD score. The point with this that I want to make is that it seems that there are compensated patients who do have a component of inflammation, and this maybe it will increase their risk of developing events, which is something that will need to be evaluated further in the future. What about liver insufficiency? You would think that in the compensated patients, you don't have liver insufficiency. It's obviously that the patient is not yellow on a normal thing, because this is a very, very jaundice. Alone jaundice in the compensated patient is a very rare event. And this is why it does not define decompensation. In this study here, which is the study that I had previously mentioned, we had seen that patients who had low level of albumin, and for those who are not clinicians, this low level is even within the norm. Normal is, according to laboratories, but 3.5 to 4.5 or 3.5 to 4.5 approximately. Patients who have an albumin under 4 have an increase in the risk of decompensation, while patients who have above this cutoff have a lower risk of decompensation during follow-up. And this in a group of compensated patients was also associated with death. So Among the changes that you can see of liver insufficiency in the compensated patient, it seems that this decrease in albumin is something that comes relatively early on, and even in the compensated patient, this degree of liver insufficiency can identify a risk, a patient who has an increased risk of decompensation and death, as I said. What about in decompensation? Again, in decompensated cirrhosis, and so in compensated cirrhosis, I said, it's mainly portal hypertension that drives the course of the disease. In decompensated cirrhosis, it's the full-fledged picture. Portal hypertension seems to reach a plateau, and systemic inflammation and liver insufficiency increases progressively. And I will take you through these figures where we have these clinical stages of acute chronic liver disease. Just to say, the light gray is compensated, the dark gray is decompensated. I think that's enough explanation to make my point. We see here the MELD, which is an estimation of, you could say, liver insufficiency. It's a score that is based on the calculation with bilirubin, INR, and creatinine. We have a Child-Pugh score, which is perhaps more well known, has variables of liver function as well as clinical variables, the HVPG, as I said before, and these two parameters of inflammation. And so we see here how the HVPG rises in the compensated, but then seems to plateau, as I said, and mainly here, the interleukin 6 and the CRP rises greatly in the decompensated phase of the disease, as well as the MELD score. And here below we can see specifically the different parameters: HVPG, CRP, interleukin 6, and MELD. And again, we had also seen in decompensated cirrhosis that in patients with very high MELD score, I mean above 15, unfortunately in this study we did not do the calculations with a cutoff of MELD of 10, but the sole presence of severe portal hypertension, which is an HVPG above 20, had no impact on survival. So we see here the survival of patients with a MELD from 15 to 24, and here the survival of patients above 24. And these are patients here with high portal pressure and low natrium. That is a very bad combination. And here the patients with just high, the one or the other. And here are the patients who'd have not a high portal pressure and a normal natrium. And what we can see here is the alone existence of a high portal pressure without the serum sodium component has no impact on survival, in contrast to patients in the compensated phase. And again, we know here that in patients with decompensated cirrhosis, I'm sorry here for this mistake, this should be systemic inflammation, they seem to have an increase in systemic inflammation. This is well known, well established. It seems to be different though according to the different complications of the cirrhosis, which I find quite interesting. And you have a progressive increase according to these classification of patients with acute decompensation and with different trajectories: stable decompensated, unstable decompensated, pre-ACLF seems to have more inflammation. So the summary is that in decompensated cirrhosis, portal hypertension comes to a plateau, systemic inflammation gains a role, liver insufficiency gains a role. But what about so I've showed you that there's an interaction between these different pathophysiological mechanisms. What about the effect of treatment aimed at these mechanisms? So I'm going to go through mainly treatments for portal hypertension and systemic inflammation. Since we have no treatment for liver insufficiency, I will not talk about this. First of all, portal hypertension. So what is the interaction between the things? And I will be talking about beta blockers and TIPS. So we know that the use of beta blockers to prevent first decompensation, especially the use of carvedilol, which has a greater effect, has a stronger effect at least at reducing portal pressure, prevents the first decompensation. This was shown in the PREDESI, the landmark PREDESI trial, and then further evaluated in individual patient data meta-analysis from Candid Villanueva, where they saw that patients on carvedilol had a lower incidence of first decompensation and, very interesting, a lower incidence of death. Also in the decompensated phase, patients also have a decrease in the incidence of other. So what I did not say is that here this lower incidence of first decompensation was actually not only due to a lower incidence of bleeding, which is the indication for which beta blockers was traditionally developed for the prevention of first and further bleeding, but the main effect was an effect on the development of ascites. And further studies have shown that patients with beta blockers who are hemodynamic responders have a lower incidence of refractory ascites, hepatorenal syndrome, and can also have a positive impact on death. And this is just to show that beta blockers have these beneficial effects both in compensated and decompensated cirrhosis. But we know that the patients on beta blockers have also on a decrease of intestinal have a decrease in intestinal permeability, and this is not only specific of patients who are hemodynamic responders. And this is again a study from Thomas Reiberger, where he evaluated at baseline and after the introduction of beta blockers, the HVPG, and you can see obviously there was a decrease in HVPG, but most interestingly, he had a decrease in intestinal permeability index, a decrease in LBP and interleukin-6, and this was independent of hemodynamic response. And 2 years ago, I saw this study in EASL presented by Rainer Wiest from Bern, which he evaluated the effect of the administration of beta blockers and beta-adrenergic hyperstimulation on intestinal permeability. So what he had, this is a BDL animal model, and he evaluated intestinal permeability by albumin extravasation. He provoked on a beta-adrenergic hyperstimulation by giving isoprotenerol, and then he gave some animals propanolol, a beta blocker. And what you could see here is that the albumin extravasation reduced in the animals who received the beta blocker. And he also saw that the beta-adrenergic hyperstimulation, so this hyperstimulation, had a reduction in the concentration of endothelial intracellular junctions. So this is very interesting. It's perhaps an explanation of this non-hemodynamic effect. We also have clinical data because we know that patients with ACLF, so these are patients with organ failure, on beta blockers have improved survival and lower white blood cells. This is a study from Raj Mukherjee and Rajiv Jalan, and they saw that ACLF on beta blockers survived more, as I said. And you can see here what they saw is that the probability of the patients on beta blockers, which are the light blue, of improving their ACLF was much higher than the dark blue, which are the ones who were not on beta blockers. They had less likelihood of improving and more likelihood of worsening their ACLF. And finally, we can see here the white blood cell count of the different degrees of ACLF. For those of you who are not familiar, ACLF is organ failure. So ACLF grade 2 has at least 2 organ failures. ACLF grade 3 has 3 organ failures. This is logical, this is worse. And we can see patients here without beta blockers and with beta blockers, and we can see that there is lower, at least in ACLF 1 and 2, lower white blood cell count in those patients on beta blockers. And again, the Vienna group evaluated the effect of initiation of beta blocker and the changes in systemic inflammation. And they saw that there were changes in systemic inflammation independent of HVPG changes. And in this study here, we have the baseline measurements and the post beta blocker. We have here obviously HVPG with a reduction, and we also have the white blood cells, but we also saw a reduction. And here we can see this reduction. This reduction was most evident in patients with Child-Pugh-C patients, and they could define a sort of white blood cell response, which they defined arbitrarily with a 15% decrease in white blood cells, and this was independently associated to further decompensation, overall mortality in an analysis adjusted for HVPG. So there seems to be a non-pressure non-pressure dependent or a portal pressure independent effect of beta blockers. So the beta blockers have effects beyond their effect on portal hypertension. But in the end, us hepatologists, especially us hepatologists who work in portal hypertension, have the idea that beta blockers were treating the portal hypertension. But actually, beta blocker antagonizes the stimulation of beta receptors that happens as a consequence of the sympathetic nervous system activation. And this activation of sympathetic nervous system happens in cirrhosis, and it has many effects. So that it's not only everything that happens with beta blockers, doesn't have to be everything due to the effect on portal pressure, but can be due to other, that we are counteracting other effects that may be deleterious in patients with cirrhosis and this activation. What about TIPS? So for those of you who are not clinicians and not familiar, TIPS is I didn't think of putting in a diagram to show this, but I will explain it. Transjugular, through the jugular vein, intrahepatic portosystemic shunt. This is a permanent shunt that is placed in the liver, connecting the portal vein to the hepatic vein, and leads to a great decrease in portal pressure. So we know that the use of TIPS reduces the incidence of further decompensation and death. And here we can see the results of this study of Hélène Larue that were presented in the past Baveno. And we can see the incidence of further decompensation in patients with TIPS compared to standard of care, and the survival of patients with TIPS compared to standard of care. And the implantation of TIPS leads to a reduction in systemic inflammation. So we can see here from this study from the Hanover group, where we see the C-reactive protein at baseline and after 6 to 12 months. And you see that there is a decrease, and they evaluated a number of cytokines, interleukin 1b, interleukin 6, interleukin 2, TNF-alpha, interleukin 10, and so on. And you can see that over the time, these are the different follow-up points, which were every 1 month, 3 months, 6 months, and 12 months. And you can see that there is a decrease in inflammation over time after putting in the TIPS. And there was no correlation between the magnitude of the decrease in these systemic inflammation markers and the decrease of the portosystemic gradient, suggesting that TIPS also has TIPS, which is pure portal hypertension treatment, has an effect on systemic inflammation, the same as the beta blockers also have an effect on systemic inflammation. What about the other way around? So I will just shortly comment poor absorbable antibiotics. This has been recently evaluated from Annalisa Bezzicotti in a meta-analysis where they evaluated the effects of antibiotics, rifaximin, norfloxacin, on portal pressure. And you can see here in this forest plot that there seemed to be no effect when they evaluated all studies that evaluated this aspect. But when they limited their analysis to a therapy period, a prolonged period of antibiotics, which actually makes sense. Here there is an effect of the administration of antibiotics, which is a treatment of systemic inflammation, on portal pressure, suggesting again this interaction. And finally, and I know we don't use Mars dialysis anymore, but these initial studies, and also because there's also a study that comes from my home hospital here in the Gregorio Marañón, albumin dialysis, which also evaluates or it also approaches the systemic inflammation. In this study from Vega Catalina, who was here, but she's still there, from Vega Catalina and Rafa Bañares, they evaluated HVPG, baseline 4 hours and 8 hours, and after the different sessions. And you see that with these albumin dialysis sessions, where you remove these cytokines that are driving the inflammation, you have a reduction in HVPG. And the Rajiv Jalan group also compared it to patients on normal dialysis, which are here with this dotted line. And you can see that this effect did not happen in patients on normal dialysis. It was only observed in these patients with Mars. I'm very curious to see if this also happens with the newer systems such as Dialife. And I'm coming to the end of my talk. These are my sort of take-home messages. In cirrhosis, portal hypertension, liver insufficiency, systemic inflammation are the main pathophysiological mechanisms that drive the course of the disease. Portal hypertension has a main role in the compensated, while systemic inflammation and liver insufficiency gain relevance in decompensated disease. Treatments that address portal hypertension or systemic inflammation have an impact on the other. So these two mechanisms, and that's obvious because I showed that, these two mechanisms are really interact and are involved. And the interaction with liver insufficiency is less well established. And here, what I know in clinics, liver insufficiency, the compensated decrease of albumin, not good. The decompensated hypoglycemia, attention, the patient's going to die. But everything that happens in between, the functions that you start losing, we do not have information regarding this. And what drives this liver insufficiency? We do not have information. And then the interaction, as you say, with the systemic inflammation, I think there's a lot to discuss there, because I guess that systemic inflammation also worsens liver insufficiency. You perhaps can even instruct us on this topic, because you know a lot about the topic. So to give a bit of historical perspective on this, there was this window hypothesis where it was suggested that there is a window that opens for the beneficial effects of beta blockers, and then there was a window that closes for the administration of beta blockers. I am not so sure that there is a window that closes. What I do think, though, is that patients on beta blockers with very advanced cirrhosis need intense monitorization of this beta blocker therapy. We have to be careful that we maintain, and this was shown by the data from Agustin van Rafa, the study of Luis Tellez, that we have to avoid that the renal perfusion pressure decreases. Also from more data from Hanover, it is important that we check the blood pressure, that we don't just give the pill and forget. We have to continuously monitor these patients, check their blood pressure, and make sure that they are not going too hypotensive. I do not think there is no patient that I would, obviously if the patient has acute renal failure in the context of hepatorenal syndrome, here I obviously remove beta blockers, but I would not, a decompensated cirrhotic patient who is at home, I would not consider removing the beta blockers, even if he was very advanced, as long as the blood pressure is good and the kidney doesn't worsen. So the impact on survival this is we have been analyzing this aspect, and not all first decompensations have the same impact on survival. So the definition of first decompensation can be, there's a lot of discussion about what is the definition of first decompensation, the inclusion or non-inclusion of jaundice, and the inclusion or non-inclusion of hepatic encephalopathy, because hepatic encephalopathy, some studies have said that it's a very common cause of first decompensation, for example, in MASLD patients. But in clinical practice, it's not that, at least me, I'm not seeing so many patients who have hepatic encephalopathy alone as first decompensation. So there seems to be a difference in the impact on survival of the first decompensations, where some of the decompensating events have worse survival, and others, like variceal bleeding, have a not as worse impact on survival. And I think that it is important, and what until now we have never evaluated in depth, is the control of the etiology of the liver disease. So when you have a patient, this is particularly easy, obviously, with viral, and also sometimes with alcohol, when they stop bleeding, the impact of this control of the etiology, this impacts survival massively, and also the decompensating event. So I think that we have to also evaluate the impact of the different decompensating events according to the control of the primary cause of the liver disease. I'm not sure I answered your question. So for now, when we talk about stratification of risk in compensated cirrhosis, this is mainly based on the presence of clinically significant portal hypertension. So you have compensated cirrhosis with and without clinically significant portal hypertension, but you're talking about something beyond this. This is what you're meaning. How can we refine patients further on besides this? Well, I think I would have to really think about that, because I'm not so sure I can answer your question so on the spot. But it is for sure that we do need to further granularity in this group of patients. We have to distinguish also in the compensated patients, there is control of the etiology of the liver disease. And these patients also have a complete different natural history than those who do not have control of the etiology of liver disease. So I think that for sure this is something that we have to take in mind when we want to risk stratify our patients. Obviously, the presence of portal hypertension, as told you, with the clinically significant portal hypertension, and the presence of a shrinking of the liver is not, at least in my experience, I don't know what you think, but in my experience, it's not something that you see so much in the compensated, but this major shrinking is more something that you see in the decompensated cirrhosis. I wouldn't say this. And further on, so here on the spot, without thinking more about it, I cannot say anything else, but this would be control. The etiology of liver disease, I think, is major. It has a major, well, we know that it has a major impact in the natural history, and we have to always consider this now when we want to risk stratify our patients. So we know that at least in the setting of viral hepatitis C, we have seen that if you have a sustained virological response and you have a reduction in liver stiffness measurement, one could contemplate removing the beta blockers. But in general, there is no data to support that you can say, okay, I can take out the beta blockers. If you have, though, a biopsy and you do not see the cirrhosis anymore, in this patient, then if you do not see the cirrhosis, in this patient, I would do a hemodynamic study. And if if he would have no increase in portal pressure, I would remove the beta blocker. If the patient doesn't have cirrhosis anymore, with the clinically significant portal hypertension has reversed. And I think in these patients, one could remove the beta blockers, but there is not data to support this. In my practice, what I do, the best patient for recompensation is the alcohol cirrhotic who has stopped drinking. This is the best patients. And in these patients, I have no problem, especially when I see, I like very much to see the course of the albumin, the INR, the improvement of the liver function. I always use this to motivate my patients so that they, you're doing a good job. Look, it's improving everything. We're taking out drugs. And I take them out slowly, both the diuretics and the rifaximin and the lactulose. I always do it stepwise. And I have never experienced, as long as they maintain without drinking, I have never experienced that they start drinking again. This whole thing, the discussion about the definition of recompensation, we could sit here until the evening and continue discussing. The idea of this recompensation, obviously we have compensated with a median survival above 10, and we have the decompensated with a median survival of around 20 to 24. But in this decompensated is a mixed group because it's patients who also recompensate in there. This is our older data. What is the long-term survival of the recompensated patients? Does he go back to the compensated stage? This is obviously highly dependent on the control of other factors, like if they get fat, mainly. If they get fat or other comorbidities. And so I think that in the years to come, and we both know that this will be heavily discussed in the next Baveno Consensus Conference. There are a lot of papers coming out about recompensation. Super interesting topic. Also with big implications regarding wait list for liver transplantation, with the delisting of patients, with everything that this means for the patient, his family, etc. when this happens. So the question is approaching the issue of carvedilol is a special beta blocker. It's not like the classical non-selective beta blockers, that is propranolol. Carvedilol has an additional effect and leads to a greater reduction in portal pressure, but carvedilol also reduces blood pressure. And in this patient, the question that Antonio said, when the blood pressure is already 90, I would most likely leave him on propranolol. I would not change to carvedilol. The other option is to change to carvedilol, but control the blood pressure greatly, because some patients do have a decrease in blood pressure. I most likely would leave him on propranolol.
Thank you, Cristina.
Thank you very much.
And finally, I would like to thank the organizers, Jordi Gracia and Javier Cubero, for the effort in bringing us all together again in this new edition of the Libre Seminars, and also show my gratitude to the speakers for sharing their knowledge with us. So thank you all for your active participation, and we will see again in Barcelona in June. Thank you.